Good afternoon here in Europe. Good morning in America. We have this now interesting round of talks on issues related to the treatment of pneumonia in COVID-19. And we have three experts here to talk about different topics related to this area. Dr. Pelosi from Italy, Dr. Rosart from Toronto, Canada, and Dr. Artigas from Barcelona, Spain. We have 15 minutes for each talk, as is the case in this conference. And then we will have 10 final minutes for discussion or questions. So first, we have slight change in the order. So first, Dr. Artigas will talk, then Professor Rosart, and finally Professor Pelosi or Professor Ball. I think he's the one who will talk from Dr. Pelosi's team.
Thank you very much, Jose Angel, and thank you to the organizers of this fantastic meeting for inviting me. And in the next minutes, I will try to summarize a new idea to use the local treatment with anticoagulants to treat the COVID-19. So these are my potential disclosures. I was received and I was participating in the scientific advisory board from Grifols and for Novartis. And also I received some grants of research from Grifols and Fisher and Paykel. In the next minutes, I will just go through to review the pathophysiology of acute lung injury, especially focus on the coagulopathy, and then to move to the systemic anticoagulation and the local anticoagulation treatment, and finally the conclusion. So as we know, the inflammation and coagulation is a key feature in patients with classic ARDS, and in preclinical studies where there is an increase of the procoagulant activity together with a decrease in fibrinolytic activity, and the consequences is the high deposit in the alveolar space of fibrin, and it's exactly the same in patients. Patients with ARDS, they have an increase of procoagulant activity compared with other pneumonias or the controls patients, and this is also together with the decrease of the fibrinolytic activity when we compare with the control patients. So it seems then that in bowel samples there is a high level of the coagulation activity compared with the plasma, and that suggests that there is an intraalveolar source of this lung injury according to the changes of the blood coagulation activities. It was demonstrated an increase in tissue factor and in the thrombomodulin, and also of the inhibitor of the fibrinolysis. This is just an example to show to you how the fibrin move from the vascular space to the alveolar space, and this is a fantastic substrate to have adherence with PML cells and to activate the pro-inflammatory response. We know today that in COVID-19, this virus, the COVID-19, is linked and with and bound with especially with pneumocystis type 2. And one of the characteristics of this disease is the activation of the inflammatory response through the resident alveolar macrophage and the activation of PML cells. And one of the characteristics of these patients, especially in patients with type L, I mean those patients that they have a severe hypoxemia, but with quite preserved lung compliance, is these patients has an increase of the inflammatory thrombosis in the microcirculation. So the pathophysiology is that the SARS COVID-19 virus is bonded to through the S protein to the receptor of angioconverting enzyme 2, facilitating the introduction in the cells and then to replicate this virus. And these produce an excessive immune response with that we call the cytokine storm, and a local and systemic inflammatory response that is characterized by an hypercoagulability as an imbalance of procoagulant and anticoagulant proteins, and also a diffuse endothelitis that is related with vasoconstriction and switch to a procoagulant phenotype in the injuries of endothelial cells. So the consequences of this is the hypoxemia, severe hypoxemia, related to the microthrombosis and also the microthrombosis, especially in a more classic picture of ARDS. So Julie Helms described the risk of thrombosis in this very interesting paper, and that he demonstrated compared with non-COVID ARDS patients that there is in COVID ARDS, there is a significantly more coagulopathy, a significantly more thrombosis, and a significantly more pulmonary embolism, as I show you in this example of thoracic CT scan, where there is a typical thrombosis in this pulmonary artery. Because of this, many physicians and investigators recommend to do an anticoagulant treatment as early as possible. But the problem is that the prophylactic anticoagulation is not enough to prevent this procoagulant activity in these patients, and only in patients that they use higher doses or therapeutic doses of enoxaparin in this study, they were able to decrease the D-dimer and improve gas exchange. The problem of to use anticoagulant treatments by systemic infusion is the risk of bleeding. And in general, intensivists don't like to use systemic anticoagulation because of this. Saying this, there are now a major interest to move from the systemic anticoagulation to more local pulmonary treatment using different anticoagulants. And I will concentrate in the rest of my presentation on the nebulized heparin. Nebulized heparin has many properties. First, heparin, the unfractioned heparin, has a close link and facilitating the bonding of these COVID-19 virus to the heparin and avoiding the link of the COVID-19 to the angiotensin converting enzyme 2 and the introduction this virus in the cells of the alveolar type 2 cells. Also the heparin has an anticoagulant activity, preventing the increase of deposits of fibrin and the blood coagulation in the microcirculation. Also, heparin has an anti-inflammatory effect, especially with the reduction of the production of many pro-inflammatory cytokines through the resident activity of the macrophage. And also heparin is reducing the neutrophil extracellular tracts that are playing a key role in the inflammatory response. And finally, we know now also that heparin has a mucolytic activity, and therefore to try to prevent the mucus blocks and the atelectasis in this disease. So the evidence of nebulized fraction heparin to improve lung injury is summarized in this paper that we published recently in Critical Care, and I recommend to you, if you want to go through in detail of this information, to just have a look on this paper. But just to try to summarize to you, the evidence in preclinical studies is summarized in this large of number of studies. That, just to summarize to you, is that the message is that there is in preclinical studies, there is a reduction of pulmonary coagulation, a reduction of inflammation, and an improvement in oxygenation. Just to show you an example of our group in rats that where we induce an acute lung injury, the administration by nebulization of heparin in these rats produce and improve in lung histology if you compare with the rats that they receive inhaled endotoxin, and this is after the nebulization of heparin. What is the clinical evidence in clinical studies? There is a large number of studies, especially in the classic areas. And just to summarize to you is that fraction heparin produce in general a reduction of coagulation, a reduction of death space as a consequence of the previous effect, and an improvement in gas exchange and an increase of day free of mechanical ventilation. Here's an example. This is a classic study published by Dixon, and you see that the patients that they receive heparin, nebulized heparin, they have a shorter time of mechanical ventilation compared with the placebo. And finally, this is the last paper submitted, and I hope be approved to the Lancet Respiratory Disease from the same group, and they were in 256 patients with ARDS in a phase 3 trial. They were able to demonstrate a reduce in the patients treated with nebulized heparin, a reduce of incidence of ARDS. So there is an attenuation of lung injury, fewer cases of new ARDS, less deterioration of gas exchange through the John Burrell lung injury score, and a faster recovery with more survivors residing at home at day 60. So nebulized heparin in mechanical ventilation is easy to apply. You need a good system to for nebulization as a mesh system that is connected through a T adapter to the inspiratory limb of the mechanical ventilation. And this system can be synchronized or not with the mechanical ventilation. And now there is in the future, we are planning to do a meta trial of individual trials in Australia, Ireland, Spain, UK, and probably USA. The idea is to include patients with mechanical ventilation, patients that they have already COVID-19 infection, and to nebulize heparin sodium of 25,000 units every 6 hours during 10 days, and to compare this with the standard care. And the primary outcome is the alive and the days of free mechanical ventilation. Is also, we are trying to do simultaneously and the same study, but in patients, in awake patients with spontaneous mechanical ventilation. And this is just to show you a patient with a face mask that is the expiratory valve is connected, or can be connected to an antiviral filter. And also probably, why not, to use as a classic system that we are using for to give bronchodilators in patients with chronic lung disease at home. That means that this is mainly the interest is to use this strategy in a very early phase of COVID-19 infection, because the unfractionated heparin has an antiviral activity, and the objective is to decrease the virus load in these patients. So just to conclude, we can say that there is a strong biological rationale to test in randomized controlled trial the antiviral effect through the to SARS COVID-19 spike protein. There is a strong biological rationale for the anticoagulant, local anticoagulant effect, and the anti-inflammatory effects and the mucolytic effects. So both are these four properties of the heparin are key to be successful in the treatment of these patients. And I think there is a strong clinical rationale to test in randomized controlled trial, because we know now the nebulization of heparin is excellent, safe. They has excellent safety profile without no effect in the blood coagulation in the systemic circulation, and also we know now that we have positive studies of the attenuation of lung injury and ARDS. And probably in the future we need to think on the potential public health implications, especially to prevent the spread of infection using at-home system to spread unfractionated heparin to decrease the viral load in these patients. So I want to finish to thanks all my team, especially to Marta Camprovi and also Fernanda Puig and Raquel Guillamat to help me during these years on the research program on coagulation in acute lung injury. And thank you very much. I will be happy.
And Professor Brossard will talk about mechanical ventilation and lung recruitment in COVID-19 versus non-COVID-19 ARDS.
Thank you very much for the invitation and for this fantastic organization. It's really impressive. It's a pleasure to be connected with so many people. I'm going to briefly review many of the questions which have been discussed about how to ventilate patients with COVID-19 ARDS or CARDS. And so this is my conflict of interest. I've been working with a number of companies to get grants or equipment. And among the many debates around COVID-19, the management of respiratory distress and mechanical ventilation has been in the center of many questioning. And as you all know, it even went into the lay press, and people were saying, well, is mechanical ventilation good for patients, or is it killing patients? So there has been a lot of excitement. And many people try to bring their own support to the question. And Luciano Gattinoni has been one of the first, after the peak wave in Italy, to try to propose some thoughts about these patients, how different they could be, and how different could be the management. And in an editorial in the Blue Journal, they say, well, what we see, these are data from COVID patients. What we see is a wide range of compliance, but also many patients with high shunt, which means a lot of hypoxemia. And it seems that some of these patients are very hypoxemic, so high shunt, but do not have a low compliance, which is what we usually expect. So they say maybe it's not a typical ARDS, and maybe they should be managed differently. So this has created a lot of questioning about the validity of this assumption. And later on, in a further correspondence, Luciano Gattinoni mentioned this graph, which is not very strong correlation, but which suggested that maybe the compliance, the decrease in compliance was a matter of time. So how long since the beginning of the symptoms, and so maybe it was not different phenotypes, as he said initially, but different stages of the disease. However, since we started to have more data about these patients, this is one of the first study from New York, which went after Italy, of course. We saw that the range of compliance was very similar to what we see in ARDS usually. So you see on the bottom this graph showing the compliance at day 1, 2, 3, etc. You see the mean value is around 30 milliliters per centimeter of water, so very classical value in ARDS. And you have a lot of dispersion. So some patients have very low compliance, some patients have high compliance. So definitely there is a need for thinking of the individual patient. You cannot have an approach for all patients. And there has been also a lot of discussion about whether these patients should be intubated early versus late. Martin Tobin said basically that we should not intubate someone only for hypoxemia. He said many patients are intubated only because of hypoxemia, but without dyspnea or distress. And this has been called the silent hypoxemia, or in the lay press, it was called happy hypoxemia. And his recommendation was to say, do not intubate if the patient do not have clinical signs of respiratory distress, work of breathing, struggling, which of course is a clinical judgment. And you can imagine, well, you have experienced, a lot of you, that in case of a big surge and many patients coming at the same time, this this becomes difficult to individualize. But at the same time, there is the risk that if the patient is not intubated early on, the breathing pattern of the patients may unintentionally create what we call self-inflicted lung injury, which means that this is illustrated in this schema where you have lung edema, impaired gas exchange. This increase the drive, and this increased drive increase the effort, the risk of high transpiratory pressure, high tidal volume, or Pendeluft, which means a regional distension, decreased alveolar pressure, which can increase hydrostatic pulmonary edema, and the increasing self-inflicted lung injury like a vicious circle. So to break this vicious circle, mechanical ventilation is needed. And of course, that's difficult to detect clinically because we don't have a biomarker. I put this X-ray, they come from Peru, from Dr. Roldan. And you know that Peru is one of the countries in the world the most impacted by COVID. And he described to me all these patients coming with very, very severe bilateral infiltrates from the beginning. And this was one of his slides where the patient is intubated on volume control. You see the plateau pressure is around 28, the PEEP is at 4. So very, very high driving pressure of 24 for a tidal volume of less than 300. So already very early on, this patient has a very low compliance. And you could imagine that he has been intubated late. I don't know for this one, of course, but and he has developed self-inflicted lung injury. So there is a difficult balance for the clinician to find this. And as I said, it's very difficult to diagnose. When the patient is on the ventilator, you may see the same thing when the patient is breathing very strongly. This is a very interesting recent paper in the Blue Journal because this is a series of patients with COVID who have been intubated, controlled ventilation in the initial phase. And as soon as they improved, they were switched to assisted ventilation like pressure support. And many of them, not all of them, of course, but many of them worsened. So they say they relapsed. Okay, so they relapsed their respiratory failure. And these authors have been able to follow an index of respiratory drive, which is available on every ventilator, the P01 or occlusion pressure. And it's remarkable to see that most of the patients who had this relapse, so this secondary worsening when they were breathing spontaneously, had very high P.1. So in line with the concept of the self-inflicted lung injury. So this is something which can be monitored on the ventilator. And for instance, we published a study showing that when the P.1 is above 4, you can strongly suspect that the effort may be very high and maybe excessive. So again, you need to incorporate that into your clinical judgment, but it may be one of the arguments to give more sedation to the patient. Again, there has been discussion about the dead space, and one of the easy way to surrogate for dead space is called the ventilatory ratio. So it's the formula is here is very simple. You just take minute ventilation, PCO2, and you make the ratio to the ideal product of minute ventilation based on predicted body weight and a normal PCO2. And very soon people say we have patients who are hypercapnic, and this is interesting because it may suggest that there is dead space due to a vascular component. If you have vascular obstruction and if you have ventilation, it's really dead space. However, I want to warn you to be very careful about that. First, because the ventilatory ratio, all these calculations depend on the tidal volume. For instance, here, they have slightly increased the tidal volume. The ventilatory ratio went down. So it's not an absolute value. It depends on the setting. And also, it's important to keep in mind that the dead space in ICU patient in general and in ARDS in general is high. So this is the paper we did with François Lelouch. And you have tidal volume against respiratory rate. And the blue line indicates the classical settings for patients in the operating room, which is giving 100 ml per kilogram of predicted body weight per minute of minute ventilation. Okay, 100 ml per kilogram. And these points indicate studies which have been done in the OR. But this curve, the red dots, indicates 50% higher minute ventilation of 150 ml per kilogram predicted body weight. And all these data points are taken from studies in ICU patients or ARDS. So by nature, patients with ARDS, you need higher level of minute ventilation. And you know that even with that, many of these patients were slightly hypercapnic. So for instance, look at if you want a tidal volume of 6, you have to know that you need to have a respiratory rate of at least 25, maybe 30, okay? So if you use a respiratory rate of 20, your patient will be hypercapnic, whether it's COVID or not. And in addition, there is another factor. You see here the curve shifted upward, meaning much more minute ventilation. This is when you increase the instrumental dead space by adding a filter. And of course, with COVID, people have been scared, have put extra precaution, more filters in the system, whereas I think what you need is a closed circuit and a filter at the end on the expiratory line. But when you put the filter at the Y-piece, you markedly increase the instrumental dead space and you need, again, more ventilation. So this may explain part of the discussion about ventilatory ratio. Because yes, I think there is a vascular component, but I have to say that when I looked at the autopsy studies from patients with COVID, there was not so much of vascular disease. There were microthrombi, and some patients had pulmonary emboli. That's absolutely true. But at least what was presented in the autopsy study was not so different from classical ARDS. So again, yes, it's a specific kind of ARDS. There are some specificity, but not that many. And one of the big questions has been, are these patients recruitable? So should they receive high PEEP? Should they receive low PEEP? And you know, the classical technique to measure the recruitability is a CT scan. It's a very fascinating technique for research, but it's impossible for clinical setting. Look at this classical example from the patient here has density in the dependent part, and increasing the pressure up to 45 does not open these densities. So it just distends the rest of the lung. So this patient is not recruitable. Please have a look at the size of the heart. This is very interesting because the heart is squeezed. When the patient is not recruiter, usually the hemodynamic with high PEEP is poor. And this is an example of a recruitable patients, which mean that you reopen the part which were non-aerated at low pressure. Of course, the clinical question is, can you keep it open? That's really the important one. But at least you see that there are major differences between patients. It's difficult to detect at the bedside. Until recently, I would say we had no technique to know whether a patient is recruitable or not. One interesting technique is the EIT, electrical impedance tomography, which gives an image which looks like a CT image. You see the non-dependent and the dependent part, and you see here, for instance, the effect of PEEP, which is increasing ventilation. It just shows ventilation. It does not show the anatomical structure. But you have more ventilation in the dependent part when you increase PEEP. So you have recruited this part of the lung. And we were interested by this technique because if you see this patient the next day, we kept the same PEEP, but now the patient was ventilated primarily in the dependent part, which does not make sense. And we say, okay, the only explanation why is less ventilated in a non-dependent part is because of hyperinflation. So we are giving too much PEEP. So that was interesting. We immediately reduced the PEEP. So this is an interesting technique because it can be used both for detecting if you recruit and if you hyperdistant. And you can make very nice curves showing the distribution of the collapse and of the hyperdistension when you decrease the PEEP. For instance, you need to start from a high PEEP, you go down progressively, and then you have to decide where you put the PEEP. I'm not saying this is the right way to do, but just to show that in this example, for instance, these authors decided to put the PEEP at the minimal collapse. This is a bit arbitrary, it could be discussed, but then this is the PEEP level they used, and this what would have been a high PEEP FiO2 table. So in these few patients, this technique gave very high PEEP levels. Okay, so you cannot say that all these patients are like that. And what we have proposed is to use a technique not only for COVID, of course, which at the bedside can tell you whether you have an increase in volume when you increase PEEP, which is not related to the distension of the baby lung. This is what we call the recruitment to inflation ratio. And I have no time today to explain it in detail. The principle is very simple. We do a drop in PEEP from 15 to 5, and we measure the exhaled volume. So the patient has to be completely passive. And if the exhaled volume is exactly predicted by the compliance at low PEEP, it means we did not gain any extra volume due to recruitment. When it's higher, we have recruited the part of the lung. So for those of you who are interested, this is a web page, rtmaven.com, where you can find a video explaining how to do this technique on any ventilator. Very simple. And we then measure how much of the volume is going into the recruitment, how much is going into the inflation. So the higher the recruitment to inflation ratio, the higher is the recruitability of the lung. And just to finish, we used this technique very early. So we had contact with people in Wuhan, in China for the first wave. And you see they measured recruitment to inflation ratio. This is two groups of patients. In this patient, they were not prone. They found very little potential for recruitment. The value was below 0.5, which means not recruitable. Interestingly, in the patients who were prone, the recruitment to inflation ratio increased after the proning session. So proning may be good for the patient, not only for by itself, but also by making the lung more recruitable. And this is my last slide. To finish, we did a study with the group in Rome, Domenico Greco and Massimo Antonelli. We compared COVID to non-COVID patients, matching every patient for the same oxygenation and same severity and age. And you see the comparison here. The compliance, yes, it seems it's maybe slightly higher in COVID patients, so maybe confirming Luciano Gattinoni's hypothesis, but you see also you have all kinds of compliance. And back to the recruitment to inflation ratio, we did not see a significant difference between COVID and non-COVID. And again, it's difficult to see, but you have a lot of individual values, which means that more than a global approach, you need to individualize for every patient, each individual patient, to know whether the patient is recruitable or not. I'll finish there, and again, was very happy to participate, and please visit our blog, coemv.ca, to continue this discussion. Thank you.
Great pleasure to be here with you, and I will try to talk a bit about our experience on COVID-19 pneumonia, as our interpretation is not traditional RDS. I have no conflict of interest for this specific lecture. And this is the result of a large multidisciplinary team, which is characterized by anesthesiologist and intensive care physician, infectivologist, pneumonologist, and anatomopathologist. And this is the video recording of the first intubation in our hospital on February 29, 2020. And as you can see here, we really faced a new ward in intensive care medicine. Now we have to go back to almost 20 years ago when with Professor Rocco, we developed the concept of pulmonary and extrapulmonary RDS. Pulmonary RDS, when the insult is coming from the outside to the alveoli and promoting an injury, mainly first to the epithelial layer. And the second is in the direct lung injury as a pneumonia. And then extrapulmonary RDS, when the lesion is coming from the extrapulmonary foci, from inflammatory mediators in the blood, and then leading to the injury, and this is typical from sepsis. In the traditional RDS, the differentiation between the two mechanisms is not always easy. Overall, what we found was that pulmonary, as compared to extrapulmonary RDS, was characterized by increased alveolar epithelium in the type 1 and type 2 cell damage, with a prevalent alveolar neutrophils and apoptotic neutrophils with fibrotic exudate, but with lower alveolar collapse and increase in local interleukin. Further, we found that in pulmonary RDS was characterized by increased edema, lower edema in the interstitial space and increased collagen fibers. Further, increased cell infiltration in the extracellular matrix. The capillary endothelium, at least in traditional RDS, was normal in pulmonary as compared to extrapulmonary RDS, while there was an increase in the blood of interleukins and TNF-alpha much more than in pulmonary RDS. We look at the post-mortem evidence and findings for COVID-19 as compared to traditional RDS. And as you can see here, the lung is a different color, more yellow-brown, fibrotic with bulle in the visceral and the pneumomediastinal part with area of hemorrhage. We performed a specific technique with cryobiopsy by our interventional pulmonologist, Dr. Barisone, with the support of our colleagues, especially Dr. Ball, performing this technique, which is commonly used to monitor and to detect cancer tumors. And this technique allowed us to perform biopsy just 20 minutes after death during mechanical ventilation, so completely different from traditional autopsy. We perform autopsy in patients after 25 days, and we found different patterns. The early death pattern, as you can see here in panel A and B, with a lesion of the alveolar side in the brown, in the black arrows, and hyaline membrane or necrotic material lying on the alveolar surface. And this is typical at the radiological finding with area apparently well aerated. And the mid-DAD, typical of the ground glass or gray zones with a complete alteration in the alveolar and vascular structure and initial area of fibrosis. And the late date pattern, typical of the white areas, and you can see here a complete alteration in the alveolar and vascular structure. We did not find, interestingly, major thrombosis, but this is likely due to the late death of these patients and the anticoagulation that we performed on our patients. Further, we look at the peripheral areas, the so-called honeycomb areas, as depicted in the squares, red squares, and you see an alteration in the vascular again and alveolar structure with mucosinosis in the alveoli, and in the last panel you see the smooth mast cells in red in the larger fibrotic interstitial space, which indicates a complete disorganization in the fibrotic response. So to conclude, from the anatomopathological point of view, we found that COVID-19 patient was characterized by pneumolysis, vascular lysis, alveolar cell infiltration, alveolar mucosinosis, and fibrosis. We performed CT scan in many patients, and we found different phenotypes. Phenotype 1 characterized by multiple mocal overperfused ground glass opacities and normally aerated areas, and these kind of patients are likely to be supported by non-invasive respiratory ventilation. Phenotype 2, which is more rare, characterized by atelectatic and peribronchial opacities, inhomogeneously distributed and hyperperfused, associated or not with phenotype 1. And finally, phenotype 1, characterized by patchy RDS-like pattern, inhomogeneously distributed with hyper and hypoperfused areas are associated with phenotype 1. Overall, we found that in critically ill patients who required intubation, phenotype 1 was rare, while phenotype 3 was more frequent. And phenotype 3 evoluted as pneumolysis, vascular lysis, fibrosis, and more complicated with possible superinfection after 12 to 15 days of mechanical ventilation. We also look at the evolution of the disease from intubated, and after extubation, we maintained patients from 3 to 10 days in a post-intensive care unit, where we were able to follow these patients also by CT scan. And as you can see here, we found that in most of patients after extubation, with almost normal clinical parameters, we found a fibrotic response in the lung. And now we are evaluating this fibrotic response is maintained with MOS or not. We look carefully at the regional perfusion because it's very important to understand the mechanism leading to VAQ and shunt in COVID-19 pneumonia. And as you can see here in traditional RDS, we have higher areas of high VAQ in the non-dependent part of the lung in supine position, and area with true shunt in the most dependent part, while in the middle areas are characterized by low VAQ ratio. Different characterization of regional perfusion may be explained by vasoconstriction, epoxy vasoconstriction, swelling of the endothelial cells, obstruction, so microthrombosis, or collapse due to the superimposed weight of the lung. And epoxy pulmonary vasoconstriction, the heart repression and posture may dramatically modify the regional perfusion. In traditional RDS, we know that the perfusion is gravitational, and as you can see here in red, more perfusion, in blue, less perfusion, and we found more perfusion in the dependent part of the lung, characterized by more consolidation or atelectasis. And the alteration in oxygenation, the PO2-FO2 ratio, was lower at the increase in the proportion of perfusion to voxel with fractional water higher than 0.7. So in traditional RDS, in the dependent lung region are characterized by consolidation and more frequently by atelectasis, with a gravitational regional perfusion, and hypoxia may clearly be explained by true shunt. We used dual energy computed tomography in COVID-19 patient. This was the first patient we analyzed, and this was the first images. And this technique allowed us to mesh together the regional changes in the gas volume and tissue volume with the amount of blood volume. And we know that blood volume is associated with pulmonary perfusion. We know that in the lung weight in normal lungs is around 800 grams. In traditional RDS lung, the weight is around 1 kilo 800 grams. So the excess tissue in RDS is around 1 kilo. In phenotype 1, we found a lung weight of 1 kilo and 100 grams with an excess tissue mass of around 300 grams. On the contrary, in phenotype 3, we found a lung weight of 1 kilo and 600 grams with an excess of 800 grams. But the regional perfusion, as you can see here, was not gravitational, as found in traditional RDS, but was anti-gravitational. So overall, the distribution of perfusion in COVID-19 patients was higher in the ventral as compared to dorsal lung region, as also higher in the apical with less densities as compared to caudal with more densities. We look also at the distribution of shunt, VAQ ratio, and perfusion defect in these patients. We found, as you see in the left part of the panel, that the overall true VAQ less than 1 indicates low VAQ. There was a progressive increase from hyper-aerated, normal-aerated, and poor-aerated tissue. So again, that space was higher in the poorly aerated tissue as compared to other lung compartments. On the other side, in the non-aerated tissue, we found that the amount of non-aerated tissue was almost 30%. So overall, in the non-aerated tissue, 50 to 60. And also we found that before or after non-invasive respiratory support, there was an increase in the density in the lung with increasing shunt. So the increase in shunt and further deterioration and saturation not responding to FL2 is a good determinant for progressive worsening of the lung function in COVID-19 patients. We look also at the effects of PEEP from PEEP-8 to PEEP-16 in COVID-19 patients, and we did not find any change in lung weight, while in traditional RDS we observed a reduction in the lung weight with an increase in total lung volume of around 400 milliliters, equivalent to 400 milliliters in gas volume. The distribution of CT numbers in upstream WD was not different with the tuned level of PEEP, and we also observed an increase of around 2 to 3% in hyper-aerated tissue and normal aerated tissue, increasing PEEP from 8 to 16, while a decrease in polyaerated tissue and non-aerated tissue of around 3%. So overall, we found poor alveolar recruitment with higher PEEP at 16 centimeters of water in less and more severe cases of COVID-19 pneumonia. We found amount of recruitable tissue in COVID-19 phenotype 3 of 30 grams, which is equivalent to 4% of chest tissue mass, while in traditional RDS, the amount of recruitable tissue was around 200 grams, equivalent to 20% of chest tissue. So the potential for recruitment in COVID-19 patient was not different in phenotype H or L with low or high compliance, suggesting that respiratory mechanics does not predict which patient may recruit or more or less, with application of different level of PEEP, no difference between VIP and no VIP, no difference between survivors and non-survivors. We also found that the amount of hyperaeration, hyperated tissue increasing PEEP from 8 to 16 was associated with the amount of normally aerated tissue at PEEP 8. So higher is the amount of aeration at lower PEEP level, higher is the amount of hyperinflation occurring with increased level of PEEP. We also found that the amount of PO2 at a higher level of PEEP but lower level of FiO2, 50%, was lower than when we used lower level of PEEP at 8 with higher level of FiO2. So higher FiO2 is the first determinant for increasing oxygenation in these patients. In fact, the amount of shunt did not major changes from PEEP 8 to 16, but more importantly, the compliance was reduced in all patients when we increased PEEP from 8 to 16 centimeters of water. We also look at the distribution of oxygenation in this patient with supine and prone position. We have two models in this condition that we proposed years ago. The first one in which there is no recruitment of densities in the dorsal part of the lung from supine to prone, and in this case, the improvement in oxygenation is associated with flow diversion, and this is associated with an increase in PCO2 or no change in PCO2. On the other side, in traditional RDS, we usually observe a higher amount of recruitment, with higher amount of regional ventilation in the dorsal part, so PO2 is associated with a real recruitment of the lung, and also with a reduction in PO2. We examined the effects of supine and prone position in this patient, and as you can see here, there was no changes in the distributional density in the dorsal part. So the flow diversion is the main mechanism explaining improvement in oxygenation in prone position in COVID-19 patients. Overall, we found that in prone position, CT scan was associated with a reduction in lung volume and increased tissue mass, no alveolar recruitment in the dorsal lung regions, and redistribution of perfusion towards ventral lung regions. There were similar results in non-invasive and invasive mechanical ventilation, and we remember that prone position during non-invasive ventilation may also delay intubation. We use prone position in 34% of the patients, but only 40% of the patients significantly improve oxygenation during prone, and only 20% of them maintained an improvement in oxygenation where the position is supine. Further, PCO2 increasing more than 77% of the patients. So we can modelize the traditional RDS with alveolar capillary lesion with more edema, atelectasis, lower compliance, and higher perfusion in the dependent part of the lung. And so recruitment from black circles here to blue circles here, maintaining perfusion in the dorsal part of the lung. So the response in oxygenation in traditional RDS is associated with better aeration, recruitment, but not perfusion redistribution. On the contrary, in COVID-19 patients, we found a pulmonary vascular lysis with gas volume substituted by cellular necrosis, infiltration, and fibrosis and consolidation. So higher perfusion in non-dependent part of the lung, with poor or no recruitment, with higher pressure or prone position. So the response in oxygenation was associated with a redistribution of perfusion and non-better aeration and recruitment. So hypoxia in COVID-19 may be explained by lower VQ in poorly aerated lung tissue due to hyperperfusion, to higher shunt in non-aerated lung tissue with microthrombosis, vascular lysis effect, which may be also partially protective, and higher VQ in poorly aerated lung tissue with hyperperfusion, increasing ventilation ratio. So hypoxia is clearly explained by higher compliance with less inspiratory effort and low VQ due to the poorly aerated tissue, which is best responsive to higher FiO2. When hypoxia developed to SAD hypoxia, which means lower or higher compliance, And the hypoxemia is due to shunting non-aerated tissue. This is poor responsive to higher pressure. And that's why the reason that we have to intubate early the hypoxemic patient when they start to deteriorate to SED hypoxia. So we suggest to close the lung and keep them resting to minimize ventilator-induced lung injury with lower tidal volume, plateau pressure, PIP, and driving pressure. And just gently ventilate the aerated lung, keeping the consolidated lung at rest. And minimize saturation between 88 to 95% or PO2 range between 55 to 80 mmHg at minimal PIP, minimizing right ventricular impairment. We have to remember that...
Sorry, we have to be finishing in briefly.
Yes, just 2 slides, I finished.
Okay, sorry, Paolo.
Lower saturation at lower pH and higher PCO2 with lower IPO2. And also the oxygen transport should be maintained by increasing the hemoglobin to 10 to 13 grams per deciliter. So to conclude, COVID-19 is a complex systemic disease. It's not traditional RDS. The first bullet is pneumonia with pulmonary vascular lysis. The second bullet is coagulation with thrombosis and hemorrhage. And the third bullet is fibrosis. We suggest anti-inflammatory with corticosteroid, anticoagulant, antiviral in the early phase, and protective respiratory support. Finally, how to ventilate patients with COVID-19. We have to be patient. In phenotype 1, we suggest non-invasive respiratory support, but early intubation, if no clinical improvement within 2 to 6 hours. In phenotype 3 and phenotype 1, non-improving non-invasive respiratory support, early intubation and CMV. With protective ventilation with plateau pressure below 25-27, driving pressure below 12 to 14, and P between 8 to 13 with higher FI2, and use requiem maneuver only as a rescue. Minimizing the targets of oxygenation and optimizing oxygen transport with increasing level of hemoglobin. And in phenotype 3, we can try prone position, but remembering that the improvement in oxygenation are poorly symptomatic with perfusion distribution and not alveolar recruitment. Thank you very much.
What do you think, or how do you think that hypoxemia is explained? Or Paolo? What is
yes, for me is a clear answer, as I showed you, okay. Because in the hypoxia you have the role of poorly aerated tissue. This is the issue. That what we found is that the poorly aerated tissue, which is not major role in traditional RDS, has a major role here, and poorly aerated tissue is associated with higher compliance. So you don't feel dyspnea, but hypoxia is due to the low VQ in the poorly aerated tissue. And when you develop it, so what I call SED hypoxia, so more shunt, this means that you are progressively deteriorating. That's why I think that we have to intubate this patient very early when they start to deteriorate oxygenation, because you move from SED, from happy to SED, and we have not to delay too much towards the SED. Otherwise, so I am in favor of early intubation when possible. That's why. Okay. When the patient do not respond anymore to higher FI2, this means that it's true shunt, and you are moving from low VQ to true shunt.
Okay, understood. Thank you. And the other question maybe for you too, and for or Antonio, is: do you think that the treatment of the microthrombi that we see is anticoagulation or immunosuppression, since they are more in the context of immune thrombosis rather than systemic emboli?
No, I think that is both, you know, as you mentioned, we need to treat the exaggerated or the storm of cytokines, but in addition to control the thrombosis. And I think it makes sense to try first the nebulization of anticoagulant, because there is no effect in the peripheral circulation, and the risk of bleeding is absolutely absent. And the other possibility, and this is a question for you also, Paolo, there are some investigators that recommend to use almitrine. To potentiate the vasoconstriction that in patients with COVID-19 it disappeared. There is no, because there is no effect on the angiotensin converting enzyme 2, and probably in some patients, there is a need to increase the vasoconstriction hypoxic response.
We got some experience with nitric oxide, and we have some patients who are responding, patients are less. But we used, of course, this depends on the number of machines. Actually, we have more than 40 patients intubated again, unfortunately. And so we have not 42 machines for nitric oxide, but we got some patient good response, some patient less. We don't use almitrin, but because we cannot in Italy, but this is also an interesting issue. The problem of almitrin is that this may also increase the pulmonary artery pressure. So that in this patient may be also another issue. But of course, this issue of regional distribution of perfusion, as I show you, is very complex. So there are some areas thrombotic and other not. But I showed you that we found thrombotic areas in the atelectasis, in the consolidated. So in some way, I think that the organism tries to defend himself in order not to increase too much the true shunt with thrombosis. So thrombosis is bad, but also on the other side, thrombosis is good to minimize deterioration in oxygenation when we are going to the side hypoxia. This is at least is the model, the picture that we try to get from our perfusion data.
Okay, thank you very much, Paolo. Thank you, Antonio.
Yeah, I agree.
It's been great listening to you all.
Thanks.
I think this, and thank you to you, and it's been great. And see you around, Paolo, Antonio, and Lorenzo.
Thank you.
Thank you.
Good. Ciao Antonio. Ciao. Ciao Raimondi. Bye.
Ciao.
Ciao
Bye.
Nestor.